Welcome to the February edition of Alfred Health's Journal Club podcast. I'm Conor O'Flynn, the Alfred Emergency Department Senior Registrar for Research. And today I'm once again joined by the Academic Director for the Alfred Emergency and Trauma Centre, Professor Peter Cameron, as well as Dr. Christina Roman, who is the lead pharmacist for emergency medicine here at the Alfred, as well as being a lecturer at Monash University. Today, we have two papers up for discussion. First up, we're looking at TRAUMOX-2, an RCT comparing early restrictive and liberal oxygen therapy in trauma patients. This was published in the Journal of American Medical Association in December just gone. The second paper we're discussing is the RENOVATE trial, also from the same edition of JAMA, which is an RCT comparing high-flow nasal oxygen and NIV in patients with acute respiratory failure.
Paper 1.
So, TRAUMOX-2. It looked at adult trauma patients and compared a restrictive oxygen strategy targeting oxygen saturations greater than 94% for 8 hours with a liberal oxygen strategy of an FiO2 greater than 0.6 for 8 hours. The primary outcome was a composite of death and/or major respiratory complications within 30 days. The design, so TRAUMOX-2 is a multi-centre international open-label RCT, which included 15 pre-hospital bases and 5 major trauma centres in Denmark, the Netherlands and Switzerland. Around 2,000 patients were initially randomised, with about 75% of those going on to complete the trial. The target sample size of 1420 was based upon the findings from TRAUMOX-1, the pilot, and the assumption that the estimated event rate would be around 15% in the control arm and 10% in the intervention arm. And this would provide 80% power to detect a 33% relative reduction in the primary outcome. Patients were enrolled either in the pre-hospital setting or upon arrival to the trauma centre, irrespective of whether they had suffered blunt or penetrating injuries, as long as they were over 18, required full trauma team activation, were expected to remain in hospital for at least 24 hours and didn't meet any of the exclusion criteria, which included cardiac arrest, secondary transfer, suspected carbon monoxide, and suspected carbon monoxide poisoning. And to my eye, when looking at the baseline characteristics, they seem to create comparable study and target populations. Their analysis utilised binary logistic regressions to report odds ratios on the primary outcome, whose 95% confidence intervals included 1. This led them to conclude, and this is verbatim, in adult trauma patients, a restrictive oxygen strategy compared with a liberal oxygen strategy initiated in the pre-hospital setting or on trauma centre admission for a duration of 8 hours did not significantly reduce death and/or major respiratory complications within 30 days. So, for me, they've made a fairly big statement at the end with very little wiggle room. Prof, do you think that the work they've done justifies their conclusion?
Yeah, well, the problem is that I'm not a big believer in composite outcomes, although they do separate them out. But the number of patients who died is not that great for a start. And then, like if you look at the sort of big trials that have been positive, like the crash studies or whatever, they had 20,000 at-risk patients, and there was a 1 or 2% difference in mortality. This study was not powered to do that. So that's the first thing. The second thing is that there weren't that many patients where it was likely to make a difference. So they gave the oxygen for 8 hours. They justified that by saying there was some evidence that 8 hours would make a difference. But in a multi-trauma patient with multiple complications and multiple interventions, it's hard to believe that this one little part of it is going to make a big difference. It's a problem with all these trauma trials. You've got such a heterogeneous group. There was one thing that stuck out, though, in this was that they were more likely to get hypoxic. That was actually significant. So episodes of hypoxia. And in my mind, especially in that first period where things are a little bit unstable, that first few hours, the one thing you do want to avoid is hypoxemia and episodes of that, because for a brain injured patient that's not good. And the only way, or the best way to avoid hypoxemia, is to give people a liberal amount of oxygen until you're satisfied that you've got everything stabilised, their lungs are okay, and they're not going to suddenly stop breathing or do anything stupid on you. And then you can kick back and relax and very neatly titrate the oxygen. So in my mind, this study didn't really add much, in that it sort of didn't show a huge difference in a heterogeneous group in a relatively small population of patients, other than that you got a few more episodes of hypoxia, which is what you'd expect if you didn't use liberal oxygen.
Mm. Well, I tried to explain this study to someone non-medical, and they went, "Well, what's the harm though?" And then you find yourself trying to explain free radicals and all this, but then over 8 hours, is there a genuine patient harm in this time span for overoxygenation?
Well, there could be, but I suspect if you're looking at relative risks, then the theoretical risk of free radicals versus the practical risk of an episode of hypoxia in a brain injured patient, I know which one I'd choose. But Christina, what do you reckon?
I think it's more about maybe if you had this long-term oxygen, liberal oxygen exposure, there's that ongoing risk of what they define as respiratory compromise or distress. So there's the pneumonia definition that they had, which seemed to be, it seemed to be showing that perhaps long-term liberal oxygen is not good for you in the trauma population, but we haven't been able to capture that in the 8-hour period. So certainly more evidence is required to really define this a bit clearer.
I'd agree with that. I think some of the things that were brought up when we did this in person were that this wasn't necessarily generalizable to the population we see, because they weren't actually that sick. I think the mean trauma severity score was, I think it was definitely less than 16, but they just didn't seem that sick.
I agree.
And perhaps, there might be benefit in certain subgroups, which, we haven't really explored enough. Maybe it's the traumatic brain injury patients that we need to specifically look at and see if, liberal oxygen is beneficial there instead.
Earlier, Prof, you said you're not a fan of composite outcomes.
Neither am I, to be honest.
Fair enough. Well, for the group then,
Yeah.
why don't we like composite outcomes?
Well, from my perspective, one of the problems is the outcomes may be different for the intervention may cause different effects on different outcomes. So it might say increase respiratory complications but decrease deaths. Alternatively, it might you might also, if you like, double the effect of something if they have respiratory complications and then they die. So the reason people do it is so that they can potentially have more outcomes, so therefore increase their power without increasing the numbers of patients. But the downside is it can basically just muddy the waters.
And often what I find with composite outcomes is it's powered for one particular outcome and the other one's sort of an add-on, often not really powered for both of the outcomes. So they might have looked at, mortality, or they might have looked at respiratory compromise and then powered it for that, but then added on an extra outcome. So then it's hard to know, well, is this significant for that particular outcome if it's not powered?
The fact that the mean randomization for some of the subgroups was about 10% of the total amount of time. So they could have had been in the other arm unknowingly. So they could have been on the liberal and then switched over. And I think there was concerns about contamination bias and the fact that people would have had a 10 to 15% of the time of the intervention on the other arm before they were randomized.
Yeah. So there's again mudding of the word. Yeah. I mean, the reality is there was the possibility that they'd already had liberal oxygen pre-hospital, and then they if it's going to have an effect on the early part of reperfusion or whatever, then that may have already happened by the time they get there. So it's sort of like 1 hour versus it's not 0 versus 8 hours. It's a bit of a mix.
Yeah, which makes it really challenging then to really know, what is the benefit, and then also the fact that quite a big number, I think, have been excluded from the initial number of trauma patients that were assessed to be eligible. And then further to that, there was some exclusions based on consent, withdrawing consent, and all sorts of other things. So I think it also does not specifically help us because it's a very defined group that they've randomized and recruited to.
The bottom line is, if there is an impact, it's going to be relatively small. But as I said, the real problem is the risk as the clinician is that you're faced with a sick trauma patient who may become hypoxic. Until you've got them stabilised, you would tend to put them on high flow oxygen or high airflow oxygen until you had stabilised them. Because if you had them where they were just on the edge of the oxygen curve and then they, drop their blood pressure or whatever, they're going to become hypoxic, and that's the risk. Yeah. So
yeah, I guess it's a bit more dynamic, isn't it? In the clinical environment, you're not going to be so black and white about it.
Yeah, I think in terms of practice, I'm not changing anything based on this paper. I'm still if someone comes in sick trauma, shock index positive, they're still getting ATLS 15 liters, especially until I know what's going on. I don't. For me, as I think we made clear in the earlier, I don't think this paper does much for me in terms of practice change.
Paper 2.
So next, we're looking at the RENOVATE study. So RENOVATE looked at hospitalized adult patients with acute respiratory failure in 5 groups: immunocompetent with hypoxemia, immunocompromised with hypoxemia, COPD exacerbation, acute cardiogenic pulmonary edema, and hypoxemic COVID-19, and compared high-flow nasal oxygen to NIV, looking at a primary outcome of intubation or death within 7 days. This was a multi-center, adaptive, non-inferiority RCT conducted across 33 hospitals in Brazil. The study enrolled a total of 1,800 hospitalized adults across the 5 patient groups and ran from November 2019 to November 2023. The target sample size of 2,000 was determined by Bayesian adaptive statistical methods, and the non-inferiority margin was set at 10%. Meaning that if the high-flow nasal oxygen odds ratio was less than 1.55, it would be considered non-inferior. This margin was based upon an estimated 36% event rate for NIV in the primary outcome from a previous meta-analysis. Patients were enrolled in ICU, ED, or on the ward, provided they were hypoxemic with respiratory distress, fitted into one of the 5 already stated categories, and avoided any aspects of the exclusion criteria, which included an immediate need to intubate, hemodynamic instability, contraindications to NIV, or a ceiling of care that didn't include intubation. The study used a Bayesian hierarchical model with dynamic borrowing to assess treatment effects and managed to manufacture a set of results where the odds ratio confidence intervals for all patient groups were south of 1.55. However, when the dynamic borrowing was taken away, the results differed substantially. Nonetheless, they concluded, compared with non-invasive ventilation, high-flow nasal oxygen met pre-specified criteria for non-inferiority for the primary outcome of endotracheal intubation or death within 7 days in 4 out of the 5 groups with acute respiratory failure. Possibly more so than the last one, they've made a conclusion with a fair amount of certainty. At the in-person journal club, I made my feelings on what they said versus what's on paper quite clear. But Christina, you weren't there, so what's your view?
No, please tell me, Connor, what was your feeling? I want to know.
I'm sure it'll come out. I'm sure it'll become apparent my views on this paper. I think they've made statements that they can't necessarily justify from the data they provided. Yeah.
Definitely agree with you on that. And again, very broad groups of patients, very different systems and conditions that they're trying to use the same intervention for and show non-inferiority or even superiority. And of course, they showed non-inferiority. However, there was so much contamination, for one, with lots of patients getting both arms, particularly in the COPD groups and I think the APO groups, from memory. And then heaps of excluded patients as well. And then they've also done all of these interim analyses throughout the trial and then stopped certain groups because of futility, which is what they defined as futility. So the immunocompromised group was stopped early. There's very small numbers there, but yet they decided that it was futile to continue with that arm, and therefore they stopped early. So very small numbers there again. So it's really hard to draw conclusions from this study as well, because again, really messy, lots of different conditions that we're looking at, and perhaps looking at powering this as a composite outcome, looking at death plus intubation, that's two very different things. But also the fact that these conditions, some have more evidence for using NIV versus others. It's not powered for that individual condition. So I don't really know what to make of this. I don't see how you could use this evidence to inform your practice in the future.
I completely agree. There's lots of issues in how the study was conducted. One of the things we talked about was that it was billed as, you either have one or the other for 24 hours. But if you look at the mean amount of time, it's more a study of comparing high flow oxygen for 24 hours to NIV to anywhere ranging from 4 hours to 12 hours. It's not the protocol that they set out is not the data they present. And I think that's a big issue for me. I think other things that I thought were troubling was how they handled the amount of the deaths that they haven't written into the data. So I think it's somewhere in the 40s, and they've only written about a third of them, which is, with the small numbers we're talking about, if, for instance, all of those were in one category, you've got a completely different data set. What else we spoke about the model, so the dynamic borrowing, which are at the in-person journal club, was something that I've got the feeling, and Prof, you can agree or disagree with me, that not many people knew what it was. So would you be able to give us a bit more information about it? We asked the question and there was a lot of silence.
Yeah. Really, I mean, it's not an area that I'm expert in, obviously, but I mean, what it is you're basically utilizing where there's missing data or where there's data that's incomplete. You're utilizing other groups to impute that data, which I have a problem with. Those sorts of trials. I'd rather either have sort of complete data analysis on the data you've got, or alternatively, have measurements where you have close to 100% data. But you can do intention to treat, but where you're missing data, or where you're imputing data, I think it's always adds a degree. You then need to do sensitivity analysis to work out, whether it still makes a difference. But the big problem with this, apart from any methodological issues, was that they've got this we know that you treat COPD differently to pulmonary edema, differently to pneumonia, and yet they put them all together and then said, well, looks like it's safe. Well, I mean, I'm not going to put a COPD patient on high flow nasal oxygen and put them in the ward. It's obviously if they were, if they're hypercarbic, there's a real chance that you could kill them. And they wouldn't have picked that up in this study because there was 37 people with COPD, and 8 of those got NIV.
Mm.
So, like, what were they actually doing?
Agree.
I mean, I actually think high flow nasal oxygen is good for things like pneumonia and so forth. I think it's there are some respiratory illnesses where you might avoid, and especially those patients that can't. NIV is not very comfortable for a lot of patients, and if you can sort of stave off the hypoxemia for 24 hours whilst their body overcomes the pneumonia, you'll avoid a intubation. But I think the premise of the study that all these are basically the same is just, it's not the way we practice medicine.
I wholeheartedly agree. I think they've tried to make all respiratory failure equal without appreciating the nuances in the etiology. And I do actually feel quite sorry for them, or I feel bad for them because they were doing this, and then COVID hit. So, like November 2019 is their beginning enrollment. So I think they had this study, whether or not we agree with how they set it up, and then they had to deal with an influx of people with respiratory failure who they couldn't put into a group.
That's true. They probably weren't prepared for that.
But there's been quite a number of studies now on COPD and pulmonary edema, not so much with high flow versus non-invasive, but certainly whether non-invasive improves outcomes.
Mm.
And the evidence is pretty clear in my mind.
I think we're quite good for getting people on NIV relatively early, where we work. And I don't think anything in this study would change my view on that. I don't think, irrespective of their conclusion. I think there's too many questions about how much of each arm people got, especially in the COPD one, for us to take any meaningful conclusions from it.
But the biggest group was the hypoxemic COVID. And I think what it does show is that it's not bad for that, which we sort of knew already.
Yeah, it's true. And I think probably some of the clinicians, because it's open label, also felt the same way. And, if patients they felt were being compromised as a result of their randomization, they've probably swapped arms to NIV, for example, in the COPD group, recognizing that, that's probably what they would normally do in treating that patient.
I think that probably makes that part of the study less robust in that you're accepting that the escalation is the other arm. So you're not really comparing like with like, which is, once again, doesn't lead us to take meaningful conclusions away from it.
One of the interesting things in this was that they used a external group to do the statistical analysis. They contracted them, which was quite interesting.
Yeah, they contracted some people to produce some results, and they did produce some results. It's interesting when you compare the results with the borrowing versus without, because it's a completely different data set. Which is, as with all the things we've said, challenges how secure we are in the findings from the original data. And I actually tried to look because I read about the dynamic borrowing, no borrowing, full borrowing, and without knowing without knowing the parameters that they've set that says, oh, these are similar enough that we can borrow, it's actually quite difficult to figure out how much and where they've actually set the line for what they'll accept to take and not. And the information regarding that, either it wasn't readily available or it's far beyond my statistical knowledge for me to have understood.
Well, they say it's an approach to incorporating external data to supplement a randomized controlled trial analysis, in which external data are incorporated in a dynamic way. So, like it's sort of another way of guessing in my mind.
Yeah, without the parameters.
Intelligent guessing.
Yeah, without the parameters being readily available, and also, as you said, with outsourcing the data to someone else, they're not going to want to produce something that doesn't actually have any meaningful results. So I don't think it's mere coincidence that they've got everything below the odds ratio with the borrowing, and very little without it. That's just me being.
It's always going to be a tricky trial to do, though.
Well, I've done a couple of studies in this area, and one of the problems is it is very difficult getting clean respiratory groups. COPD with pneumonia, COPD with a little bit of heart failure. Then you get something like COVID. So getting a nice clean patient is always difficult with these trials.
Yeah, and then also that you need quite big groups to show a difference, so that makes it really challenging.
I think that for those of us that heckle from the sidelines rather than actually conducting any research, I think that when you're dealing with studies that are dealing with oxygen, we're always going to be able to complain about contamination bias, because maybe it's done pre-hospitally, but if someone's got hypoxia, in pre-hospital setting, or even before they're randomized, they're likely to get a different amount of oxygen than what you actually want to study. So I'm always going to be able to claim contamination bias, which is lovely for me.
But then if you did do it as a step wedge trial where you actually had a policy of restricted use of oxygen, and had some guideline, and you were testing the guideline as opposed to what they actually got, then that would be a robust trial in terms of testing the guideline. But
That's
that would
true.
be a very difficult study to do over a lot of sites.
Yeah, but it would at least give you a little bit of flexibility, because you could design the protocol to, give you some parameters for where you can escalate and what to do.
Yeah. Yeah, it's very hard to restrict clinicians in the heat of the moment from doing things. They're always going to not do exactly as you want them to do. Still, another study down.
And if all else fails, you can just, do some borrowing, get some answers you want.
The banks will up the mortgage rates.
Yeah. Set some mystery parameters I can figure out. And there you go. Everything works.